I'll start by saying welcome, everyone. My name is Jean Kapler. I'm chair of the Monroe County Substance Use Disorder Awareness Commission, and I am really excited that you all are joining us for this Lunch and Learn on the topic of substance use disorder in rural America or rural Indiana. This program is possible thanks to the collaboration between our commission, the IU Responding to the Addictions Crisis Grand Challenge, and the IU Center for Rural Engagement. To get things started, I'd like to introduce John Simmons. He's a commission member who was really instrumental in getting this program planned and going. So John, I'll turn it over to you.
Okay, thanks, Jean. I mean, we're really happy and proud to be co-hosting this with the Grand Challenges in the Center for Rural Engagement. Those are two groups that are doing very important work and having an amazing impact on the quality of life of people living in our rural communities in Indiana. So April Toller is going to be, she's the Executive Director of Research Communications at IU. She's going to be our moderator today. I'm going to ask April to introduce our panel. And if anyone has any questions during the presentation or during a Q&A session at the end, just put them in the chat. April will be monitoring the chat and sharing the questions with our panelists. So thank you everybody for coming, and thank you to our panelists for being part of this presentation, this Lunch and Learn.
Thanks,
April.
John. Yeah, hi, thanks, John. Hi, everyone. Thanks for being here and allowing us to be here today. So I'll tell you a little bit about the format, and then I'll introduce our panelists. Each of our panelists is going to talk a little bit about their work around this topic and what they have found in their research and work. And then we'll talk a little bit about what communities can do around this topic. And then we really want to open it up to hear from all of you in regards to what you're doing, what questions you have, that kind of thing, and kind of have more of a discussion at the end. So as John said, please feel free to put your questions or comments in the chat as we go along, and we'll monitor them. So I'm just going to start off with who I see on the screen here from left to right first. So first we have Andrea Janata. Andrea is director of IUPUI Echo Center and Center for Public Health Practice at the IU Richard M. Fairbanks School of Public Health at IUPUI. Using the Project ECHO model, Andrea develops educational programs addressing the most pressing medical and public health needs in Indiana. She manages projects such as the hepatitis C, LGBTQ+, HIV, COVID-19 response, and the Indiana Peer Education Program ECHOs. And she's also an adjunct faculty in the Department of Epidemiology. So thank you, Andrea, for being here. Welcome. Next, I'm going to go over to Cass Botts. Cass is the Healthy Hoosier Communities Liaison at IU Center for Rural Engagement. In her role, Cass links communities with the university and other resources and facilitates collaboration to effectively create and implement health initiatives. Cass was formerly the executive director of the Indiana Recovery Alliance and is passionate about her work in harm reduction strategies for substance use disorder. I'm assuming some of you probably recognize Cass on this call. So hi, Cass, welcome. And last but certainly not least is Bria Perry. Bria is Associate Vice Provost for Social Science Research at IU and a professor of sociology. Bria's research investigates the interrelated roles of social networks, biomarkers, and social psychology and social inequality in health and illness, with a particular focus on mental illness and substance use disorder. So thank you, Bria, for being here. And we're going to kick it off. Andrea, since I called on you first, we'll have you kick it off first to kind of talk a little bit about your work in regards to substance use disorder in rural areas.
Sure, absolutely. Thanks so much for having me, and good afternoon, everyone. It's great to be here and get to chat with you guys. So I'm really looking forward to the conversation. I'm a visual learner, so I'm going to share a couple of slides if that's all right. So I will go ahead and screen share. There's those. If you guys can give me a little thumbs up or something that you can see them, it's always helpful. Thanks, April. So I want to first just kind of start off with here what we know about substance use disorders and stigma. And this is not my own original research, nor is it necessarily specific to Indiana in particular, but we do know that there's stigma among healthcare professionals, and that influences patients and their care. So this study was from 2013, I believe, and it really pulled a little bit of the results section here. It shows that health professionals generally do have some negative attitudes towards patients, and those can diminish patients' feelings of empowerment and their subsequent treatment outcomes. So this is really an important issue to look at. And then I won't kill you guys with studies here, but this is another one. It's from the JAMA network, and I thought this was quite interesting. It came out last year. So in this study, they had research assistants call different residential addiction treatment programs and pose as a patient and ask about medications for opioid use disorder. And what they found was that out of the several hundred programs that they called, less than 30% offered a opioid assisted treatment program, and the continued maintenance of those. Less, only, or a few more, 31% offered short-term detoxification, but many more, 40%, didn't offer any at all or were unclear about what was available. And then there were quite a few programs that actually actively discouraged medications for opioid use disorder. So kind of in the discussion here, of these 30% of programs that actually offered the maintenance therapy, there were many others that actively discouraged this and really going against best practices. So you guys can check out that article. One more looks at what we can do. So if we know this is a problem out there, how are we able to address the training and viewpoints of clinicians through interventions, as well as that of patients and patients having self-stigma and kind of thinking of these different types of stigma that exist out in the world. A patient may be feeling certain ways about themselves, or more of that structural level stigma. And there are some effective strategies, things like motivational interviewing and communicating positive stories of people with substance use disorders. And I thought that was just really intriguing, because while this is what we know about stigma and substance use disorder, I know how it feels. I'm sorry, this picture is grainy, but this is my brother, Matthew, and he's currently recovering from a substance use disorder. My family lives in Northwest Arkansas. And I don't know how many weddings you guys have been to with cowboy hats, but here we are. And I certainly know what it's like to be in a rural community, to have a family member who's struggling with a substance use disorder, and how that stigma feels, and what it's really like to watch that person you love struggle. So I'll move into kind of what we're doing with Project Echo. And I want to give you this video. I'm actually going to play it here because I want to move through slides fairly quickly, but so that you know it is an option. So this short video, it's like less than 2 minutes, just talks about the Project Echo model. So this was developed by the University of New Mexico. It's actually spread all across the world, not looking just at substance use disorders, but many different types of complex medical conditions, and how you can use a real peer-to-peer network, a community of practice, to disseminate useful and evidence-based information to expand access to treatment. And what that really looks like is we have people who need specialty care, but there's not enough specialists, especially in rural communities, to be able to care for them. So what we do with Echo is train primary care clinicians to be able to provide more of those specialty services to really practice at the top of their license, and patients are getting the right care in the right place at the right time. So it's kind of the slogan of Echo: moving knowledge, not patients. So as we start Echo programs, something that's really important to us, we all meet on Zoom just like this. As I said, it's a community of practice, so done virtually. We have kind of regular scheduled times that we get together. It may be the first and third Thursday of the month over the lunch hour. That's our hepatitis C Echo schedule. And we start out every presentation with this slide. And really, it's important to us that we come with the understanding of talking about people as people first. So we always bring this reminder that, this whole saying about sticks and stones will break your bones, but words will never hurt you. That's not true. And we see that this really plays out in research, that the words and viewpoints that we have of people and patients make a difference in their lives and in their care. So we always kind of come with that, read it from the beginning. Oh, come on, slides. There we go. Maybe I skipped one. Okay, so in Project Echo, we have quite a few different programs. I think we're up to 13 different programs now, and we've held over 500 Echoes in the last 5 years. We've done more than 350 case presentations. Those are all de-identified patients that we talk about. And really the goal of Echo in this peer network, this virtual learning community, is to not only increase skill sets, but also to really increase job satisfaction and retention, that providers have the ability to treat their patients. We definitely know that when someone comes with a need and a need for care, that providers want to be able to help their patients. They don't want to send them away somewhere else. So Echo is something that can help them do that. They're able to have a conversation with different types of providers. So you may be a physician and you get the perspective of a family nurse practitioner, a social worker, a pharmacist, a specialist, all sorts of different types of interdisciplinary providers on Echo, and get their sense to how you can include their perspective in the care for your patient. My slides are being goofy. I don't know. Okay, here we go. So here's all the different Echo programs that we have, and I highlighted in red some that really specifically focus on substance use disorders and the comorbidities that are seen with those, or even patients that are at risk. Or LGBTQ Echo, we know that people who identify as LGBTQ have a higher risk for substance use disorders. So we talk a lot about SUD in that program. We look at treating hepatitis C and HIV, prevention of opioid use disorder in our integrated pain management Echo. And then our INPEP program is actually with the Department of Corrections. Our team goes in and trains people who are currently incarcerated to be health educators on the inside, knowing that someone who has a shared lived experience is going to be able to talk to someone else living in incarceration in a different way than a medical provider from the outside might be able to. Our InCares Echo talks with coalitions of leaders at the community level. So we've worked with about 30 different counties across Indiana at this point to mitigate opioid use and opioid overdose in their areas. We did an Echo with judges and talked about medications for opioid use disorder and how that plays out in the lives of people who come through their courts. So there's just a few examples. And then I wanted to share also some of the didactics that we do. So the brief lectures, and these are just some of the titles within the different programs. If you were to join, and I'll give you a second if you're interested to grab that QR code and you can register for an Echo right here, right now. These are some of the topics that you would get to participate in as part of our program. And it comes with some pretty sweet incentives or some benefits to you as well. So you get no cost CMEs or CEUs for physicians, pharmacists, nurses, and social workers, as well as certified health education specialists. Again, that consultation with a specialist, we call that our hub team, but also communication and networking with your peers. Really the ability to practice the top of your license. So we've seen providers who have gone from never ever treating a patient from hepatitis C to curing many, many patients from hep C. And you also get access to all of our Echo resource libraries. So anything that's talked about during an Echo is saved into a Canvas page, and we provide access to that to anybody who joins. So thank you. That's I probably went over time, April, I'm sorry. So I'll wrap it up right there. But thanks so much for allowing us to share a bit about Echo.
Oh, that was great, Andrea. Thanks so much. And I know that if people have other questions or want to connect with you on joining, they can. And so we'll move on next to Cass. I see you next. So Cass, we'll let you talk a little bit.
Yeah, hi everybody. My name again is Cass Botts. I'm the Healthy Hoosier Communities Liaison at the IU Center for Rural Engagement. I don't have a slideshow, so I'll just kind of make this more conversational, but just wanted to walk everybody through what the Center for Rural Engagement is and does, but specifically how it relates to substance use disorder through my role in the health focus area. So the Center for Rural Engagement is an organization where we connect the resources of the university with local assets to help rural communities and residents thrive. Okay, so what we do is we harness research and community engaged teaching and student service projects to address health, community resilience, and quality of place. So those are our three focus areas. So I'm the liaison for the health focus area. And what my role really is to kind of connect and network and be engaged with both the community side of things and the faculty research side of things for projects that are related to health, which is really broad. Because substance use disorder is such a salient or prescient issue in rural communities, we do have a lot of projects that really address substance use disorder, either directly or substance use disorder initiatives might kind of like be wrapped up in a part of like more of an umbrella project. So I'll talk about that a little bit more in a second. But through the work that we do, we're actually establishing a national model for university community partnerships. So we care a lot about community engaged research and participatory action research. And so what we do is kind of work with communities and really allow communities to be like community members to be the driving individuals behind any of the stuff that we're collaborating on. So it's a with rather than a like coming into kind of a relationship. So we have some internal and external projects that I'll just kind of go over that are related to substance use disorder. So one of the big ones that you may have heard of is the community health improvement plans that are part of a project by Dr. Priscilla Barnes. And what this does is after conducting community health needs assessments, the model comes up with an actual documented plan called the Community Health Improvement Plans. And Monroe County, has done this, and it's called a CHIP. So if you hear people refer to CHIPs, that's what that means. There's a lot of acronyms at the CRE. That's one of them. And so I do try to make sure that I explain any acronym that I throw out there. But if I fail to do that, please go ahead and ask during the questions section of this presentation. But so community health improvement plans, that involves like a lot of identified health related issues, but specifically there might be some substance use disorder related needs that have been identified and get worked into those plans. And so that's how that one, even though it's kind of one of those more umbrella, like broader projects, can relate to substance use disorder in rural communities. And they've led to really great coalition building initiatives, specifically in Davies County. Live Well Davies County is a really great coalition that has working groups that includes a substance use disorder and mental health working group that I'm a part of. So really love this project. It's a really good model that I hope we can bring to other communities across the state. There's also addressing youth substance use, so more related to prevention initiatives. How do we address, substance use before it becomes substance use disorder? And Dr. Kim Decker has been developing a project that relates to delivering the second step curriculum. And so it's a social emotional learning project that takes that curriculum into rural schools. And that addresses things like self-esteem and self-efficacy and things that lead to outcomes that reduce the incidence of substance use disorder. It's an evidence-based SEL program. We also have the MAT Access Project, which was by Josephine Mwangi. So that is using surveys and interviews and going into communities and finding out why medically assisted treatment access is so poor in rural counties. So medically assisted treatment, in case you don't know, is the gold standard treatment for opioid use disorder. And that can be through either methadone or Suboxone delivered just as a way to support someone in their recovery when they're dealing with chronic long-term opioid use disorder. We also have Dr. John Kiesler, who has worked on several projects with us. One is the trauma-informed care curriculum. And so this is available via Public Health and You, the Expand platform. Anybody can access it through Indiana University. And it allows people to go through and learn about trauma-informed care for healthcare providers or social services providers. People with substance use disorders have high incidences of childhood trauma, ACEs, adverse childhood experiences. And so it's really important to be able to understand that framework, to be able to interface in a way that is, healing and trauma informed with people who are living with substance use disorders. And then coming out of that, I came up with basically a trauma-informed organizational development training. If anyone's interested in learning more about that, I would love to share it with you. But if you've heard of the concept of nothing about us without us, the idea is that when you're designing services or programs that are aimed to address like a marginalized population or a stigmatized population, you shouldn't be doing that in like a paternalistic way. You really should be collaborating with the very people who are directly impacted, and directly impacted people should be, leading the programs that are designed to serve their needs, basically. So whenever you have an organization that's led by directly impacted people, having an internal trauma-informed management perspective is really important to make sure that everybody's needs are met, not in terms of the people who you're providing your services to, but actually the people like within your organization itself. So that's something that I have developed kind of like a it's in its initial phases. I did deliver it at a conference recently, and I would love to collaborate with anybody on that and kind of polish it up and deliver that to communities as well. So we also have partnered on an external project. It's a grant that we got from the Indiana Rural Opioid Consortium through the Indiana Rural Health Association. And what the CRE is doing is partnering with Antonia Sawyer, who is the founder and CEO of Ship Happens. And Ship Happens is an organization that provides mail-based naloxone distribution. And naloxone is, in case you don't know, the opioid overdose reversal drug. So within the past decade, we have really seen tremendous improvement in getting naloxone into the hands of people who are on the ground most likely to be responding to an opioid overdose. And that is actually people who use drugs themselves. So lay responders, people who are going to be there and present when overdose is happening, are able to possess, carry, and administer naloxone, which is the the way to save someone's life on the way for emergency responders to arrive. So it's not just emergency responders, it's not just EMS, it's not just police that are delivering Narcan or naloxone. Those are two names for basically the same thing, but it's people who are directly impacted themselves that can save one another's lives. And so Antonia is doing amazing work that we've collaborated with her on, getting naloxone to people who don't necessarily have that access at their local social services organizations. And so she's able to, receive requests and fulfill those requests via the mail, which is just really innovative and a great way to meet people's needs. And, as part of that grant as well, we are doing a stigma reduction piece of it for rural communities because, as we've just heard, stigma is a huge issue. And I'm developing a stigma reduction training out of, again, a Dr. John Kiesler project on stigma reduction. And we will also be partnering with local community partners, social services organizations, and just individual community members on bringing stigma reduction trainings, which will be like 1 to 2 hours into 11 target counties in rural Indiana as well. I think the last thing we're working on is HIV and HCV elimination projects. So HCV is a huge issue in Indiana, and injection drug use specifically is the primary risk factor for HCV transmission, and it's also the leading cause of incidence in the United States. There's also a very high prevalence of co-occurrence between HCV and people living with HIV. And so we are working on finding out what are some of the barriers to people getting tested, and then people getting linked to care and then ultimately cured for HCV. So I think that covers, let's see, I've got like a list here of all the projects. I think that covers all the projects that we've been working on. And again, during the questions section, I'd be happy to go into more detail on any of the ones that I mentioned. And I think that's about time.
Thanks, Cass. That was great. I know you guys have a lot of great work going on, so we really appreciate it. Bria, you're next. We'll skip over to you.
Thank you. So I'm going to share my screen and share a few slides. No, that's not right. Wait, is that right? Can you see it? Let's see. Okay, is that good? Okay. So I just want to talk a little bit today about our Addictions Grand Challenge project and the data that we're collecting in Indiana communities to better understand public stigma around opioid use disorder and how it might vary from community to community. So the goals are really to understand how addiction stigma interferes with treatment, how we can reduce stigma to increase treatment access and utilization, and how we can reduce harm to individuals and families facing addiction by trying to reduce or alleviate the additional burden of stigma. What we've done is we piggybacked on the person-to-person health interview study, which was also funded by the IU Grand Challenges, and it's the Precision Health Initiative. This is a really large omnibus health survey that took place across the state of Indiana. We use a stratified probability sample of households, which is really the gold standard in survey research, so that we can get the most accurate data. And we use face-to-face data collection by professional interviewers and collect lots of information about the participants. And with the Addictions Grand Challenge funding, we were able to add essentially a module about addiction stigma and about contact with people who had experienced addiction. We were able to add this to the P2P study, and we supplemented in 2 ways in addition to adding the module. So we added cases in the most opioid affected counties in Indiana, which were Marion, Scott, and Fayette. And then we also followed up P2P respondents who identified as non-medical opioid users, so we could ask them a lot of questions about self-stigma and about their experiences with providers, access to MOUD, and other kinds of questions. And here in green are the counties that we have collected data in for the P2P and for which we have information about addiction stigma. Another thing we did in the study that was pretty cool that I won't talk a lot about, but we collected a lot of measures of stigma. So we have these really comprehensive measures so that we can sort of try to fully understand the wide range of ways that stigma affects people with opioid use disorder or who use non-medical opioids, and also how it affects their families and providers who treat them, et cetera. So I'm going to show you just some preliminary findings because that's the most fun thing about collecting data is that you get to show your results, and usually it's what people are most interested in. So I'll sort of just give you a snapshot really quickly of what's going on in Indiana. So stigmatizing beliefs about people with opioid use disorder are quite high, quite strong in Indiana. So just as an example, about 1/3 of Hoosiers think that opioid use disorder is caused by bad character. 57% say that someone with OUD is likely to be violent towards others. 84% feel that that person would be unpredictable. 65% feel that they can't manage their own finances, and 43% think that someone with OUD cannot be a good parent. We also look at consequences of public stigma in terms of the likelihood of social exclusion or the likelihood of being rejected or discriminated against. And here we also see pretty alarming figures, especially in the domains of work and marriage. So for example, 71% of Hoosiers said they would not want to work closely on a job with someone who had opioid use disorder, and 69% would not want that person to marry into their family. Even if we're talking about sort of more distant social domains, we still see pretty alarming numbers. So 39% would not want to spend an evening socializing with someone with OUD. 35% wouldn't want to be friends with that person. 42% would not want them as a neighbor, which obviously has implications for residential treatment programs. Again, 0.3 or 30% would not want a group home for someone with MOUD in their neighborhood. We find also that these attitudes then translate into a lack of public support for treatment. So, for example, what's shown here is the relationship between stigmatizing beliefs and exclusionary sentiments, which were sort of a combination of those 2 slides that I last showed you, and support for MAT or for MOUD or medication for opioid use disorder. And so as people express more stigmatizing attitudes, their support for making that kind of treatment freely available in their communities goes down. And of course, public sentiment affects what politicians and other policymakers do. We also show that higher levels of stigma are associated with a lack of public support for harm reduction. And so these are the 2 relationships that you see here. So the more stigmatizing someone's beliefs and the more they want to exclude someone with opioid use disorder, the less support they have for things like needle exchange programs, for naloxone distribution, and those kind of harm reduction programs. So again, stigma translating into real sort of problematic support or lack of support for things that we know work for people with addiction. In terms of those individuals who reported non-medical opioid use, we found that 85% of people in our sample who had received treatment for OUD said it helped in their recovery. So they do believe that treatment works, but less than half of them actually had sought treatment. So about 4 out of 10 or 40%. And we found that stigma is a major barrier to seeking treatment among people who engage in non-medical opioid use in Indiana. So some of the sort of most commonly talked about barriers to access are that you can't afford treatment. So 65% indicated that was why they hadn't received treatment. 59% thought it wasn't serious enough. 33% said that they didn't have the time to engage in treatment, but 56%, so right sort of on par with these other major drivers of treatment avoidance, was that they didn't want to be stigmatized, or that they were afraid others would find out. So stigma is having, really very real effects in our communities. And I put together a little slide about rural counties because that's what we're talking about today. And we find that rural counties are more affected by opioid use disorder, and they also hold more stigmatizing beliefs, which is sort of counterintuitive because usually you find that people who are more personally affected by a stigmatizing condition hold less stigma. So family members, for example, of people who have OUD report much lower levels of stigma. But that doesn't seem to work at the community level, which is really important to keep in mind. So for example, we find that compared to people in our metro areas, those in rural counties are more likely to report knowing someone with a drug addiction problem. They're more likely to report that adults in their community often use prescription drugs in ways that are not prescribed or to get high. So that's 69% and 68% compared to about 40% of those in metro areas. So that's a really huge difference. So people in rural counties are perceiving opioids as a problem. And so I think what we need to do is find a way to leverage that towards addressing the problem rather than towards higher levels of stigma, which is what we're currently seeing. So people in rural counties are reporting higher levels of all kinds of stigma, and they also see more stigma in their community, even if they don't report it. So they state that they're more likely to state that getting treatment for addiction would make someone an outsider in their community, or would lead to a loss of friends, or would result in limited opportunities. So there really is something going on in the culture of rural counties that's important to pay attention to. In terms of next steps and ways in which we would love to work with all of you, we've just gotten our final survey weights for these data, but we are our next step is to publish a set of sort of best practices for developing precision interventions to address addiction stigma, essentially in different communities. We're also going to disseminate community assessments to policymakers and stakeholder groups in different counties, which is kind of like a county report card, so that you know what stigma looks like in your community and can then use that to try to address it through interventions or policy changes. And then we're also partnering with other IU researchers and community groups to inform anti-stigma interventions, including one of the ones that Cass talked about. One of our postdocs works with her in Scott County, or works with the CRE in Scott County, developing an intervention to try to reduce stigma there. So that's kind of what we're up to, and I would be happy to answer any questions in the Q&A.
Thanks, Bria. I'm going to go backwards now and kind of just start with you, since we've got you on the line here. You talked a little bit about stigma. So what can people in rural communities do? How do we move the needle in rural communities? And I know you talk a lot of your work with stigma, and kind of also how we approach stigma campaigns and how you reach people. What are some things that these communities can do, particularly if, probably everyone on this call gets it and knows, but what can we do to kind of move the needle with others in the community?
Yeah, I mean, I think one of the things that we find is that having contact with people who've experienced addiction is one of the best ways to combat it. And also just sort of demonstrating that it is a treatable condition, essentially, and that these people's lives have worth, right? Even if you use drugs or use drugs in the past, your life has worth. You matter to people. And so starting the conversation, not keeping addiction sort of in the closet, not hiding it, but talking about your experiences is really important, because sort of word of mouth experiences discussing stigma or discussing addiction with other people are going to be much more powerful in changing minds than, you know, a public service announcement or something that you would see online or on TV. So that's the first thing, is don't be afraid to talk about it. Additionally, I think that, you know, increasing support for, thanks so much, for harm reduction, and increasing MOUD so that people have access to the things that they need to get back to work, to, you know, be in recovery, to fulfill their regular social roles so that they can get back out there in the community and be interacting with, you know, people who don't have addiction. That's one of the best ways to reduce stigma, is by knowing someone, you know, who's awesome and who's, you know, a coworker, a friend, or whatever, that has successfully recovered, and is doing really well. That's, you know, interacting with those kinds of people is one of the best ways. So getting individuals back into the community, and sort of out of hiding, is really important. So anything we can, any policies we can do, any resources we can devote to that are going to be really beneficial. I'm sure other people have other
Yes.
feelings about it.
Thanks. Cass, we'll go over to you and talk a little bit about what are some things that communities can do to improve the lives of those with substance use disorder.
Yeah, I mean, I feel like stigma is really the biggest thing, like working on internal stigma, and making a commitment to like your own reduction of stigma is one of the biggest things that individuals can do. I mean, having the conversations amongst, you know, your family and friends and coworkers, and speaking up if you hear something that unsettles you, if you're someone who's kind of already on that path of the internal stigma reduction, is obviously a big thing. I think that one of the things I've thought about in rural communities is that, you know, harm reduction programs are very important in terms of addressing substance use disorder issues that folks are facing. And I think that there are a lot of individuals that exist in communities who, you know, are actually friendly to harm reduction, but don't, you know, feel like they're the person to maybe kind of like start one up, or even find the people who might be able to start one up. And so I think like I want to encourage people, if you are, you know, harm reduction friendly, or like interested in harm reduction, or consider yourself a harm reductionist as an individual, you're exactly the person to start having those conversations in your communities, because they aren't going to start up out of nowhere. These programs have to be approved by local governing bodies like the county commissioners. And we have one of our lovely county commissioners from Monroe County here who has been crucial to the Monroe County Certain Services Program being able to exist. But, you know, someone has to start the conversation. That's not going to happen from the top down, I don't think. Usually it takes one individual, and Antonia Sawyer, you know, who says like, I care about this thing and nobody's doing it. And I guess like, you know, it takes like a sense of like leadership basically. And so one of the projects that I want to start developing is kind of like a harm reduction startup toolkit. And that's something I'll be working on with the center, where it can, you know, help somebody who might be kind of tangentially just like interested in it, understand what steps might need to be taken to get these programs started up in the communities that don't already have them. Because only at most ever 9 of these programs have existed in Indiana out of 92 counties. So, you know, that's, you know, very low saturation in terms of harm reduction services. We need people to, you know, feel inspired and kind of be activated to get the programs going. So that's something that I want to do whenever I go into communities, is kind of identify who are those people, who are those potential leaders who just kind of need the encouragement to start working on it.
Thanks. And Andrea, I know also, you know, access to treatment, access for physicians and others who need the training or the extra. And I know that's what ECHO works, right? And connecting people and providing resources that you might not have. Can you talk, you know, is that another way, I guess, that we, you know, to address the issue in communities is providing, being able to have access to what you need to address it?
Absolutely. And I think what I really love about ECHO is that it provides, I think, just as Cass and Bria were saying, is that space to talk about your experience and if you have questions to ask, and for other people to share their positive experiences, that, you know, how rewarding and inspiring it can be to treat someone with substance use disorder and see them move through recovery. And I just appreciate the answers of both of Cass and Bria so much, because that matters. The words we use matter, you know, and even for folks who just, I think of myself before I really knew much about this, that the language and the words that we use, they matter so much, that if we call someone a substance abuser, that maybe that even sounds kind of okay, but the connotation of those words matter, and they permeate into how we feel about things. So changing language and committing to learn more and to have those conversations. And Bria, I thank you so much for sharing, you know, just the idea to talk about our own experiences more. I feel like I was very fumbly in the beginning. I don't often share about my own family. It's easier to hide behind kind of the academics of here's the studies and here's the work that I do, but to share your own personal story is very vulnerable. So I apologize for, you know, stumbling over my words in the beginning. That's not something I always have the courage to do, but I think it means so much. And that if we all did more talk about just the experiences that we have had and share that vulnerability, it really does make a difference. And I think that ECHO provides that space for providers amongst other providers, amongst other clinicians, where they can speak with someone they know and can kind of share, you know, spaces where maybe they haven't been super confident or have questions without it being in the limelight. So that's, I think, the space that ECHO provides.
Great. Well, it looks like looks like we have a question or comment here. So talking about Bria, you showed a slide talking about barrier treatment was cost. What can be done to reduce these costs in various communities aside from major federal legislative action? Does anyone have thoughts on kind of what can be done to reduce some of the cost?
Medicaid expansion, getting people enrolled into Medicaid, being an activist for better healthcare in general. I think, you know, a lot of times people that I worked with when I was like a caseworker, just sometimes they didn't have a realistic understanding of like what it took to get enrolled, and just had like an idea that it would be cost prohibitive. And that was people who were really like more eligible for Medicaid. But B, I think that we do have, like, based on like my personal perspective, poor healthcare coverage. And, you know, that's a major barrier for people who are going to be having to pay toward a deductible or some out-of-pocket costs.
Yeah, I totally agree with Cass. You know, there's also, in addition to reducing costs, I guess one of the costs is transportation, right? And because most of Indiana is a health professional shortage area with respect to addiction treatment, and especially office-based buprenorphine, then, you know, people have to figure out a way to travel to get their treatment, which is expensive and just prohibitive for many people. So that's another problem. Another major problem, which would require federal legislation, is the fact that our insurance is tied to our employment, and people who are experiencing addiction often, you know, have gaps in their employment. And so it's just a really stupid system that we have that it's tied to employment to begin with. But you know, any kind of programs that could be provided by employers to encourage treatment, that could help them maintain good employees who are otherwise just struggling with addiction or, you know, having a bad time, would be really helpful. There are some employers up north who have done that because they're having trouble attracting employees right now, and it's been super successful. So.
We have another question here. It says, so it seems like there's so much stigma-based resistance among county commissioners across Indiana. Is there anyone spearheading education of these elected officials so that they will move to supporting harm reduction programs in their counties? Does anybody have either experience with that or ideas for working with
I don't know of
officials?
anyone spearheading this right now, but that was a thought that came to mind, April, with your question about what can people do. I think commissioners often receive a stack of complaints, but if you're proud of a harm reduction program or certain service program in your community, call your commissioner and tell them that you're proud that your county has this service available for people. And that if we can start to balance some of the complaints with compliments, and I think that that makes a huge difference. Another program I heard about had people who received naloxone from an EMS provider that they, wrote thank you letters or somehow provided thank yous to EMS folks. That they don't always see people on the other side of getting through recovery and kind of having that. So coming back to say thank you, I mean, you made a pivotal change in my life or saved me so that I could be here now. So I think those types of activities make a huge difference in reducing stigma.
I know that there are organizations like the Indiana Recovery Alliance that are working on policy initiatives related to expanding actually the SSP law so that it's not just the responsibility of county commissioners to approve the programs. That's like a multi-year goal though. So one of the things I've been thinking about is there was a program that existed, a surrender services program that ended up getting shut down. And the commissioners really cited like faith-based concerns whenever they decided to shut it down. It was less discussion about like more the evidence base and more about the kind of like, what are my moral or religious related like concerns, which are often based in kind of some misconceptions about what the programs are and do. So I think that even beyond the county commissioners, maybe engaging faith leaders and pastors around these issues so that commissioners who may be listening to their pastors for leadership and guidance and support around these kinds of things can be getting that direction from people who are informed. And so I think it's important for community members to kind of develop these relationships and have these conversations, not just with elected officials, but also other leaders in their communities.
Thank you. We have another question regarding Matt. So what are the opportunities for telemedicine with Matt? I know the pandemic changed, right? Some opportunities for people and things. Where do you guys see that kind of going? Will it stay, some of the changes that were made? Will we expand on those? What do you guys think?
I do believe there was expansion of offerings with telemedicine. Most providers need to still meet with a patient at least once in person before they can have an established telemedicine patient-provider relationship. But I do think it'll be very interesting to watch what sort of policy change there is, and that would be a space to continue advocating for expansion of telemedicine with MOUD.
Does anybody else have any other questions from our attendees or comments or? So I guess, and if anyone does, feel free, but I guess as we kind of wrap things up, if our panelists would like to just kind of give a closing thought on, it sounds like obviously stigma plays such a role in almost every aspect of what's needed and can be really tough in rural communities. So any closing thoughts on kind of, for those listening, what we can do in the future, or are you hopeful that things will, turn around, or that things can move in the right direction?
I mean, I guess I could just conclude sociologists are not optimists by nature generally, because we see, how hard it is to change structure. And the studies that we've done suggest that stigma changes very slowly, but it is possible. So for example, we recently documented the first major reduction in stigma towards depression. So it is possible, it just takes a lot of work. And also, if any of you real people out there doing real things in the communities would like to use our data or, work with us in any way, please please get in touch. I'm really easy to find because I have a weird name. So just write it down. You can Google and find me. We'd be happy to work with community members. We do it a lot. So.
Well, thank you to our panelists for being here. We really appreciate it. And thank you to the Substance Use Disorder Awareness Commission for allowing us to be here. We really appreciate it. And to everyone who attended today and all the hard work that's going out there. There's so much good work happening in Indiana. And as you know, university, we just want to make sure that we're here and supporting all of our community partners and organizations to help in this fight. So we really appreciate it.
Yeah, I want to express my appreciation to the panelists. I thought it was really eye-opening, Cass. It was amazing all the different ways in which the center is reaching out to the rural communities, and some of the things you have planned for the future were really intriguing and important. And Andrea, it was great to hear how ECHO's reaching out to the different healthcare providers to help educate them. And thank you for sharing your own personal story. That took a lot of courage. And Maria, I got to tell you, your stats, just seeing those objective numbers about the impact of stigma really, I mean, you can talk about it, but when you see those numbers, it was really eye-opening. So thank you all for participating in it. I thought it was a great panel. Thank you very much.
Yes, I would just again like to thank our panelists, our moderator, and I'd like to thank everyone who joined this Lunch and Learn program. Thank you for your interest in this topic and all the work you're doing in your own communities. And I hope this is a jumping off point for you know, enriching your communities and making them more friendly for folks who are dealing with some sort of substance use disorder. So let's knock down that stigma.
May I say something? I haven't to date. I mean, I was trying to stay out of this. I am a Monroe County Commissioner. That's but I also have been part of some of the things that are going on here. And Cass knows me. If there are things that we can do at our county level, we're one of the 9 that has the syringe services program, partly because of Cass's efforts, I think, as well. So please reach out to us. We want to be there. We want to improve the lives of people in our community. Great program, by the way, too.
Well, thank you again, everyone, and take care.